Hello, EMS providers. This is Dr. V from ICEMA with another episode of From the JumpSeat. Recently, I sat down with Dr. Benjamin Archambeau, EMS fellow at Arrowhead Regional Medical Center, and had a discussion about the use of end-tidal CO2 monitoring in the pre-hospital setting. Take a listen and let me know what you think. Dr. Benjamin Archambeau, he is the current EMS fellow at Arrowhead Regional Medical Center. He's also the assistant medical director for the Inland Valley SWAT team, has been for the last 3 years. And when he's really bored, he plays with the Sangagornia search and rescue team. So we've asked him to sit down with us today and briefly talk about the end-tidal CO2 monitoring in the pre-hospital environment. I think over the last few years, this has really become a bit of a game changer. So I think it's important for us to have some really good focus on what's useful about it and how to look at it and how best to use it. With that intro, I'm going to turn it over to Ben, and he's got a brief presentation for us. Ben, it's all yours.
Great, thank you. Thank you for having me on. I just wanted to talk about it briefly here, hopefully in the next 5 minutes or so, to cover it because it's an important topic. It's gaining some popularity, but it's really important, as you'll see in the field and in the ED as well, and it's also just becoming kind of the standard of care. So it's important that everybody who is going to be using it is pretty familiar with it. So I just wanted to start with a little bit of a background on exactly what capnography is, just so we make sure that everyone starts on the same page. We kind of have the basics down before we move on to anything more complex. So carbon dioxide is a byproduct during normal cellular metabolism of every cell in the body, and it gets transported from the cells into the bloodstream, where it's then transported to the lungs and gets excreted. And we can measure that and use it for various purposes. The production of carbon dioxide in the body is dependent on multiple factors and is changing from second to second and minute to minute. But it's affected by things like cardiac output, how well the heart is working, as well as how well the tissues of the body are being perfused. It's affected by the bloodstream acid-base status, and particularly it acts as one of the mechanisms that the body uses to buffer acidosis. And depending on the metabolic demand of the different tissues and organs, whether that's something like exercising or a high metabolic state such as sepsis, can affect it as well. And then it's also obviously heavily affected by the breathing pattern of the patient and how deep and rapid they're taking breaths. So the idea behind the capnography, especially what we're using and what the standard is moving to, is that we want to use a continuous quantitative measurement of this carbon dioxide that's being exhaled. And we'll get into the specific uses and purposes in a minute here, but the idea is it's like a real-time feedback, not only of the patient's status, but what you're doing and how well your interventions are working as well. All right.
Ben, would it be fair to say that end-tidal CO2 is a very sensitive measure of ventilation, which actually gives you a lot more quicker feedback even before oxygenation is affected, that something's not going right and you should be paying attention?
Yeah, absolutely. It happens a lot faster, on the order of seconds. With a waveform, you can watch how they're breathing and you'll instantly know if they're not taking a breath. And with the numeric values that it gives you, those will change breath to breath, whereas something like pulse oximetry may take a minute or even a minute and a half to really catch up to that. So the way that we're going to be primarily using them in the pre-hospital setting is, number one, and probably most commonly as far as critical care goes, is to confirm successful endotracheal intubation. And it's not necessarily on the first breath after you pass the tube, but within, they say, about 6 to 8 breaths, you should have a pretty reliable reading about whether or not you're in the right location. It's also important during CPR, ACLS, running a code, but on both ends of the spectrum, whether you want to know if this patient is likely to achieve return of spontaneous circulation, and as well as when they have achieved return of spontaneous circulation. A lot of places, including Arrowhead, where I work, we've transitioned away from even doing things like pulse checks, and we have this as a tool to use instead, give us real-time feedback and minimize those pauses in CPR, which we all know is one of the most, if not the most important thing that you can do during CPR. And then the last category is just patients in general suffering from respiratory distress. And this can be both a diagnostic tool to see what kind of respiratory failure they're in, whether it's hypoxic or hypercapnic, as well as to assess how your interventions for that respiratory distress are doing in real time. All right, just briefly, the difference is between what we have been using in the ED and in the field and what we're trying to go to now is the quantitative or qualitative aspect of this capnometry. So what we have been using is qualitative, and those most commonly take the form of color change capnometry or CO2 detectors. And the problem with those and the problem with similar mechanisms that they really have like a binary feedback output, meaning you have on or off, positive or negative. There's no really gradation in between. And they're also very unreliable. If those those color CO2 detectors are expired, then they can give you a falsely negative reading. The pH paper has just gone bad, and so you don't know one way or the other. And it also can give you a false positive that you've achieved intubation if, for example, the patient has been bagged a lot and has a lot of carbon dioxide or air in their stomach. The other issue with them is that they're temporary. The paper will turn permanently gold, which is considered a positive reading, after only a few minutes, and at that point it becomes completely useless. So if the tube becomes dislodged or something like that, there's really no way to know the difference. Now, with the quantitative capnometry that we want to use, it's a continuous monitoring system that can be used for an indefinite amount of time. And it gives you two forms of data. It gives you waveform data, and it also gives you numerical values, which you can compare to the patient's baseline and kind of trend it, as well as what normal values are in the population. The major benefit from quantitative capnometry is that the changes in their breathing status, their acid-base status, and responses to your interventions are detected very rapidly on the order of a few seconds. As soon as they take their next breath, it's going to give you a new value, and you can see what your interventions are doing. The other thing is that it's highly accurate. It's giving you very precise readings. You've got a waveform, and you can compare one breath to the next to see on a second-to-second basis what's going on.
So a question I frequently get on this is that, do you need both, or do you need one versus the other? And it seems like you can actually argue that they have their own pros and cons and best places to use. So when you need a yes or no answer, like right after intubation, you want to know you're in the right place. A qualitative yes or no one can be very helpful and quick and easy to deploy. But certainly you don't want to stop there and move definitely over to quantitative to be able to continue monitoring. But I do think that they both have their own place in pre-hospital environment, and they can both be valuable in the right setting.
Yeah, absolutely. Looking at the waveform trend on your monitor can give you, an instant visual feedback. You don't have to do any calculations. You don't have to do any trends. You can see what the patient is doing visually. If they don't take a breath, you can look up at the monitor. If there's no waveform, then they're not breathing. All right. So the waveform capnography is better for a couple reasons, and we're using it in a couple settings that have shown to have quite a bit of clinical benefit and improved outcomes. The first and largest one is going to be this continuous CPR model. And I mentioned that briefly, but it's the idea that you don't want or need to do pauses in CPR if you can at all avoid it. There's studies out there showing that even a 10-second pulse check pause or less actually results in probably 20 to 30 seconds of decreased perfusion compared to the maximal perfusion that you can achieve with CPR. So every single pause that you take causes an insult of perfusion and ischemia and hypoxia to the patient that really has no tolerance for that. So if you can keep the capnography on and use that as your metric to see when you've obtained ROSC or whether you're even likely to obtain ROSC, then you can do a lot more effective continuous compressions and then move on to other interventions instead of constantly pausing to do these pulse checks. The second reason that it's extremely useful is this faster detections of respirations and apnea and pulse oximetry. As I mentioned before, pulse oximetry, depending on the patient's condition and their respiratory status and how much oxygen they're on to begin with, that can lag up to minutes, on average 60 to 90 seconds behind capnography, where the first time that they don't take a breath or become apneic, you'll be able to see that both in a waveform and their CO2 actually numeric value will drop as well. And then you also get almost instantaneous feedback of your treatment. So whether that's a breathing treatment, interventions such as non-invasive mechanical ventilation, or even interventions that you're doing such as fluid boluses or anything like that to correct a metabolic acidosis, this is the body's second-to-second mechanism for altering that kind of thing. And so you'll be able to see if what you're doing is effective, if the patient is getting worse, and you can make adjustments accordingly. So the information that we get, it comes in a couple forms. The one is the numeric value. It also gives us this waveform that we're talking about, which is just an easy way to eyeball it and get a general sense of what's going on. And then, as with any of these monitoring systems, the trend is really almost the most important thing for the average patient, where you're seeing, is their CO2 going up? Are their breath depth or rate going up or down? And then you can actually use that to anticipate the patient's either improvement or decline and make adjustments before some of that stuff happens and you're behind the ball. All right.
So Ben, do you think these are three different, distinctly separate data points, or you're looking at numeric values, waveforms, and trends, and you should be comfortable in understanding what each of them are telling you? Or do you think they're just three different ways of representing the same essential data?
No, they do give you a little bit of different information for each piece of data. Ideally, if you can, you want to be able to be familiar with all three ways to understand that data and be able to integrate them together. And it, just like anything else we get, a blood pressure, a heart rate, a GCS, all of that stuff is one data point. And the more of those data points that you can collect together, the better overall picture of the patient's condition you'll get. With these different scenarios, I just wanted to cover briefly how you're going to use these on a very basic level, and then you can go on and learn more about each one of these as you go and as you get better with using this. The first one is during intubation. So if you get a physiologic value or somewhere thereabouts after you've intubated a patient, that generally indicates success. And, like I said, there are some things that may throw it off initially, but after you clear any air or CO2 that might be in the stomach, 6 to 8 breaths, or in the dead space of the airways, then it should be pretty accurate as to what it's reflecting. It can also, after you've intubated and the tube is secure and you're, transporting the patient or whatever you're doing, you can keep an eye on it. And if it changes very suddenly, then you're having a problem with the patient's ventilation. Your ET tube may have been dislodged. They may be, breathing over the vent if they've regained a pulse or regained respiration. So, having an idea of what it looks like after you've intubated them and then keeping that number in mind. And if that rapidly changes, that usually signals that you need to rapidly correct it or make an intervention because something has changed in the patient's airway or respiratory status. All right, while you're ventilating them, if you're seeing either extraordinarily high or extraordinarily low, or particularly low CO2 numbers, and that usually means that you need to make an adjustment as far as their ventilation is concerned. The first sign that you'll usually see with inadequate ventilation is that their CO2 will rapidly rise. And the idea behind that is that you're not ventilating them rapidly enough, and so they're not being able to clear the tissues of the CO2 that's being produced. And you usually need to increase either the rate or the volume of your ventilations, however you're choosing to deliver those. Or if the patient's CO2 is rising, that may mean that they need an additional level of airway or respiratory intervention. Conversely, if the patient is apneic, you may actually initially see a very low CO2 because they're not exhaling any air, so no CO2 is being removed from the lungs and you're just not able to detect it. So either very high or very low are both pretty concerning. And then during CPR and ACLS, you use it again. A normal CO2 value is good. It's reassuring that you're compressions or your ventilations are adequate, but just like with the ventilation and all these other things, a particularly high number or a particularly low number are what you're really concerned about. So a very low CO2 on your waveform capnometry is going to indicate a very poor prognosis. Either the patient just can't perfuse their tissues, they have no volume, they've been down for a prolonged amount of time. It indicates either that there's no active or effective circulation of the tissues, or the tissues, particularly the cardiorespiratory system, and are no longer metabolically active, meaning the cells have already started to die. And if you get this at first and it doesn't change even despite your interventions, this is generally a very poor prognosis. And you should follow your normal guidelines for the field as far as terminating any ACLS or codes. But it's one more piece of data, again, that you can integrate saying that this person is unlikely to achieve spontaneous circulation at that point if it stays low. Conversely, if you get a rapid rise after it's been 10, 15, 20, and all of a sudden it shoots up to 40 or 70 millimeters of mercury, this may mean that you actually do have a pulse achieved, and you can stop and do a pulse check at that point, while not having to stop and do a pulse check if you're not sure. And the reason that you'll see a little bit higher number typically at that point is because they haven't had good circulation, they haven't had good ventilation while CPR is being performed, and they have no squeeze of their heart. As soon as they have return of circulation, then all of that excess CO2 that's been built up in the body needs to be cleared. So you'll typically see a rapid rise, and it'll actually be above normal, and then slowly will trend back to a normal level as you ventilate and as their tissues begin to reperfuse.
So Ben, just on the context of the intubation, wanted to point out that obviously a dislodged DT tube is a catastrophe that we definitely do not want to miss.
Sure.
They're going to happen. If you intubate enough, you will put a tube in the esophagus. That's not the problem. The problem is not identifying it. And we use several methods of verification. Obviously, visualization is the first one, then auscultations. And then in this setting, using end-tidal CO2, first maybe a yes or no answer, and then ultimately hooking it up and monitoring. I guess the important thing is not any one method is 100% proof. So you really can't skip one or the other. You got to do it all. And so if you see a good value on end-tidal CO2, don't skip the auscultation, because they all need to point to a successful, secure tube. If one of them is off, you have to be asking, A, why is that off? And is it really indicating that there is some problem with my tube? So I think it's an important piece to keep in mind.
Sort of along those lines, as with every other intervention or monitoring that we do, it's not perfect. So some things to keep in mind are that, number one, the machine from time to time needs to be calibrated. It's not necessarily on every use, but you can get false values if you're just not paying attention to it at all. So it needs regular maintenance. It does obviously require some more training. We're getting into that a little bit here today, but I encourage everybody to go out and learn a little bit on their own. There's a ton of information out there that's pretty good, and studies are being released on a regular basis as well. We mentioned it is possible to get a false positive during intubation. It's usually after the patient has been bagged without a secure airway in place and you get air into the stomach. Well, that air obviously has carbon dioxide in it. So as it gets exhaled back through the tube, once it, even in the esophagus, you will have some CO2 produced. And there's this theoretical interference of somebody who's just recently drank a carbonated beverage, because obviously they have a higher than normal carbonation content. And so you may actually get fairly high readings that can look physiologic, but that's not the case. Usually this is a temporary issue. So if you're not sure what you're getting with these numbers, give them a couple breaths, usually 6 to 8, and it'll clear. And then you should be getting a reliable number at that point after you've cleared out any extra gas that's in the stomach if you're concerned about it. You can also get falsely low readings and low blood flow states for the patient. So mainly this is going to come in the form of shock, and that's largely any type of shock because the patient's not perfusing their tissues. They're not bringing the CO2 back from their tissues to the heart and lungs. You can also see it in heart failure, especially if it's decompensated. And then anything that causes shunt physiology where the circulation is actually bypassing the lungs for one reason or another. It's inaccurate in low tidal volumes as well. And again, the same kind of reason. If you're not getting blood flow, the CO2 is not being carried to the lungs. And if you're not moving air in the lungs, it's not getting carried out of the body. So it can be just accumulating in the circulation, tissues, or lungs. So if they're taking very low volumes, then you want to be aware of that. But that should also be something that shows up on the waveform. And another reason to use both the numeric value and the waveform is if on their waveform capnometry they're using or pulling very low volumes, which is usually pretty easy to tell, then you can be suspicious of the actual numeric value you're getting. All right, so just real briefly, because we had a lot of stuff that we covered and not a lot of time, it is the new standard of care both in the pre-hospital and ED environment. So it's important to become aware of this because you're going to be using it wherever you are. It is being used because it's very fast, it's accurate, and it's continuous, above and beyond what we're doing with the qualitative measurements. Its main uses, especially in the pre-hospital environment, are going to be for CPR and ACLS, airway management, and patients in severe respiratory distress. And then most importantly, you have to familiarize yourself with the equipment interpretation, and then as much as possible, stay up as much as you can with the current guidelines and the research that's being put out, because this is one of those areas of emergency medicine and EMS that's constantly changing.
That's great, Ben. Hey, I wanted to pick your brain about something. We have in ICEMA a couple of protocols. One is the pain management protocol, and the other is our behavioral emergencies, where we are strongly recommending aggressive monitoring the patients that are medicated for either behavioral issues or for pain control with narcotics and other sensorium altering medications. And one of them is entitled Capnography and monitoring. And some people suggested that may not be necessarily the standard care, but I still think it's a good piece of equipment if you have available to use. What's your thoughts on that?
Yeah, I would say two things. Number one is, having something like waveform capnography, even if it isn't the standard of care nationally or whatever your metric is, doesn't mean that we can't do it, right? We should be continuously striving to go above and beyond what the standard of care is and be providing excellent care. And there's departments, including this area, that have done a very good job of that and have had better outcomes as a result. You have to keep in mind that national guidelines, standards, and recommendations often lag for up to 5 to 10 years after where the state of the science is at. So if it's in a guideline and you're only following the guidelines and you're not doing anything above that, then you may actually be behind the times in what people are doing out in the field or in the ED environment for that matter. My second thought on that would be that, I understand the argument about resource utilization, and obviously in the field, you've got a lot of things going on all the time, especially in the back of an ambulance. It's a lot of stuff to keep track of. It's more equipment to use, more resources to devote, and one other thing that everybody has to learn and pay attention to. But this, the reason that we use it in the first place and what it represents is something called a low frequency, high risk event, right? So chances are, even in the ED, you give somebody some sort of pain medication or, a sedative medication for whatever reason, 9 times out of 10 or even 99 times out of 100, it's, not going to create any respiratory issues, right? But every once in a while, it is. And somebody's going to go apneic from any of these medications, whether it's an opioid, benzodiazepine, or even something like ketamine. In the ED, we do see episodes of apnea with these medications. And so even though it may not be a high frequency event, it's one of those that you can't miss, right? You can't miss your patient becoming apneic. I would much rather know instantaneously, where you've got a little bit of that oxygen buffer that we talked about and you can do something about it. You got a minute to a minute and a half to play around before you're really in trouble, versus, by the time you see their pulse oximetry going down to that critical threshold of high 80s, low 90s%, you're really behind the 8 ball. And by the time you get an airway intervention in, you break out your endotracheal tube, it's in place, it's confirmed, and you're ventilating the patient, that person could arrest at that point, with whatever else they have going on. You don't know in the field. And so, however long that takes to get that stuff set up, you add a minute and a half to that of patient not breathing. Well, you're really decreasing your margin of safety with that. And so, yeah, most of the time it's going to seem like it didn't make a difference one way or the other, but you'll be thankful that you had it on when that does happen.
That's actually a very good point because I do think monitoring patients for subtle clinical changes is actually more challenging in the pre-hospital environment
Sure.
than it is in the hospital and ED environment. So having sensitive tools like this to help you and alert you early rather than later
Hmm.
is priceless. So I totally agree, and I appreciate you kind of sharing your thoughts with us on that. So with that, I think this concludes our this episode of From the Jump Seat. I want to thank Dr. Archambeau for being with us. To the audience out there, please forward any emails that you have and questions about this through the ICEMA duty officer or the ICEMA staff or myself. Our emails are on the website. I'm also soliciting input from all of you out in the EMS land about future topics that we can cover in this format with our local experts. So with that, I want to thank you again, Ben, for being with us today. And until next time.